Okay, we will call to order the January 2nd, 2025 meeting of the Oregon Home Care Commission at 10:10. Okay. And are there any others besides commissioners that are in attendance?
Adam, would you like?
Any guests?
Yeah, this is Matt Raposo, APD Long-Term Services and Supports Administrator. I'm just here just for a few minutes just to say hello during kind of the introduction here, but then I'll need to move to a different meeting, but just want to drop in and say hi.
Well, appreciate it anytime, Matt. Okay.
And then we have Adam.
Yeah, I'm here from Carewell Training as a partnership coordinator just to listen for any updates that might be relevant to our program.
Okay, thank you, Adam. We can move to discussion regarding the adoption of the agenda. Does anyone have anything to say in review?
I did send an updated agenda today. One of our guest speakers was not included on the agenda, and I think it's going to be a really great discussion today about person-centered services. So they'll be here at 12:30.
Wonderful. I have one comment. It's just a clerical error. It says adoption of October agenda. So we can move that up to today to January.
That's not on the one that I'm looking at on my screen.
Yeah, the screen says January agenda.
I think there might have been some confusion with the agendas.
I have a different copy there.
Yeah, I think there was a different copy attached to the agenda. I mean, to the appointment.
All right, I will go by the one on the screen then. All right. Any further discussion? That meeting is to take place at 12:30. Is that correct?
That's correct.
This is Commissioner Johnson. I move that we approve the agenda as it appears on the screen.
But we can't yet.
We don't have quorum until George gets here.
I thought we had quorum. Okay.
Do we want to drop down to announcements until George comes?
Yes.
Okay. Is it okay if I start the announcements, Marcia?
Yes, please do, Jenny.
Okay. Okay. I wanted to let everybody know, I know that you already know, but for the public as well, that our beloved chair, Ruth McEwen, passed away on December 25th. And losing her is a great loss for the Commission, Oregon, people with disabilities, and me personally. She was a steadfast advocate for people with disabilities for over 40 years, and I imagine probably her whole life too. She made a difference for those living in Oregon. According to Ruth, her greatest accomplishment was helping Oregon move away from the institutionalization of older adults and people with disabilities by offering community-based services. She worked very closely with Dick Ladd, who was the first administrator of the then Senior Services Division, to help Oregon become one of the first states to offer community-based services. Another of Ruth's accomplishments was working with the legislature in 1989 to pass legislation creating disability services advisory committees. She spent endless hours advocating at the state capitol and educating legislators. Ruth joined the Oregon Home Care Commission in 2015 as a representative of the Governor's Commission on Senior Services and later became a consumer representative. Ruth also served as the chair of the Senior Advisory Committee with Northwest Senior and Disability Services. Ruth held degrees in accounting, psychology, special education, and counseling. Early in her professional career, she worked as an advocate for individuals experiencing intellectual and developmental disabilities and their families. And on a final note, Ruth kept me on my toes, and she helped me push myself to do my best. And she taught me so much, and I'm sure that you learned a few things from Ruth too. She'll be sorely missed. It's such a great loss. And I wanted to open up to the commissioners and anybody else on this in this meeting to talk about Ruth if you would like to do that.
Hi, this is Commissioner Adams. Sorry that I'm late. From what I've known about Ruth was, she was someone that really liked to help people, knew her stuff, and was part of both this committee and my all-in-one system committee. She had really good ideas. I always will cherish them for a long time.
Jenny, did you say she passed away on Christmas?
Yes, she
Oh.
did. Yeah.
Well, I didn't know her very long, but I did appreciate her caring and her checking on you when you weren't feeling well, or it just seemed like she was a stalwart in the home care, a giant in the home care industry, and I learned an awful lot from her, and I appreciate her.
Ruth was the model that I tried to emulate, but never got there. She had been an advocate since her childhood. She had profound disabilities, and it's so puzzling that she was able to accomplish all that she did. But I think that she drew her strength from the Lord, and it grew her heart and her ability to push forward over obstacles that I can't believe. I'm going to borrow from what's currently being said about former President Carter, that it's a life well lived in the benefit of others. We had many a conversation about organ business and personal life, and prayed together many times on the phone. I will miss my friend, but for a short while. Thank you.
This is Commissioner Johnson. I haven't been able to have the longevity with Ruth that many of you had. Hearing the report that Ginny shared for the many, many years, her involvement in advocacy is amazing. I would probably not throw around the term hero very casually, but when we think about the advances and the ideas and the energy that Ruth brought for people with disabilities and senior services, as a recipient of those services herself and an incredibly effective advocate, in my mind, she's a hero, and has done so much. Not only her advocacy, but her passion and her ability to commit, and her commitment to commit and communicate with those decision makers and involve others in the process. She was such a model and an example, somebody who is engaged and invested in the lives of those seniors and people with disabilities. She will be deeply missed. and will never be replaced, but hopefully her memory and her successful advocacy will go on, having impact in this state for many years to come.
Thank you, Paul. I wanted to read something that Matt Raposa put in the chat. He had to leave for another meeting, but he wanted to say that Ruth was an amazing person, so kind and so kind-hearted, and truly cared and supported Oregonians who were in need of help. I will let you know when there is something, a memorial or something that's being held for Ruth. I know that her friends and family are working with Northwest Senior and Disability Services to put something together for her.
Nice, nice.
Yeah, very kind.
Jenny and commissioners, it may be appropriate at another time, but it would be wonderful to consider ways in which the commission, maybe during a memorial service or otherwise, express in public or in a sustained way our gratitude to Ruth in her memory for all that she accomplished for Oregonians.
Yeah, that's a great idea. Thank you, Paul.
Mm. And I know when the legislature opens, each time they have a time for reviewing uh, people who have advocated. And I'm wondering if it might be appropriate to contact some people, some legislators, current ones and past ones that have worked with Ruth. I know Ruth has had bills that she sponsored with others, like the lemon law for wheelchairs, and various, well, a long list, and maybe bring her recognition during that period, or whatever the legislature would wish.
Do they ever proclaim a day in someone's honor, like Ruth? I mean, I do, they do in certain aspects, but could we ask for a day dedicated to her? Is that off base, or I don't know how that works.
It may have to be voted on by a legislator. I would think.
I wouldn't think there's any problem in asking. I don't know what the protocol is, Mary, but I think that's a great suggestion, because there will be many of the legislator who would know her, others who need to know about her. And so I think that'd be wonderful. I mean, the worst result would be, no, that's not done, but I think we could pursue it. I don't know, Jenny, if that's an idea that could be.
Yeah, I'll see what's possible.
My day.
Which, and it's been such a long time that she's been working this is the reason. And so,
yeah,
it just seems that she really kind of is a giant.
Yeah, she was very well known in the legislature. She spent hours upon hours at the state capitol advocating and educating legislators.
Didn't she begin Pi Day?
Oh, I don't know. I wouldn't be surprised.
That might be an appropriate day to remember her annually. Just a thought. And I know she just short while ago had her 80th birthday.
Yeah.
It might be an appropriate day.
Just one other thought, and I know this may not be the time to go into these things, but it'd be great if ODHS or APD or both would be able to also provide some remembrance and recognition to Ruth for the whole ODHS community, to because there may be individuals who've worked with her. I'm sure there are that are unaware of her passing. That it might be also appropriate to talk with those offices and see what can be done in ODHS as well.
I believe they are. Yeah.
Okay.
But I'll follow up.
Oh, you read my mind.
So Marcia, we have the director of the Office of Developmental Disability Services coming at 10:30. So I think my suggestion is to move the public testimony down so that you have time to adopt the January agenda and approve the minutes for December.
That's a wise move. Okay, so have we adopted the agenda for this meeting yet?
This is Commissioner Johnson. I move that we adopt the agenda as it appears on the screen for this meeting.
I second the motion, Commissioner Mayor.
Okay. Those in favor say aye.
Aye.
Any negative? All right. The agenda's passed. All right. And let's review the minutes. Anyone have any comments?
I move that we approve the minutes as presented, Commissioner Mayor.
Okay, a second.
Hi, Commissioner Adams. Seconded.
I say aye.
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 Nays. The minutes have passed. And are we ready to move to our guest?
Yes, Dana Hiddle is here with us now.
From
Dana,
the
are you ready?
Good morning. I am ready. Thank you.
Hello, Dana.
Hello.
Would you share about what office you are from? And we're anxious to hear your comments.
Absolutely. Thank you so much for having me. My name is Dana Hiddle. I am currently with the Office of Developmental Disability Services, or ODDS, in the Department of Human Services. I've been in this role now for about 10 months, and I've committed to being the interim director through the long legislative session. Been really diving in and learning, relearning a lot of things about ODDS. In my previous role, I came from the Oregon Health Authority. I was over there for about 10 years. And I served as the state Medicaid director over there, overseeing the Oregon Health Plan, and the deputy state Medicaid director before that. So coming back to ODHS feels like coming back to home, and really diving in and seeing what's been happening in the last 10 plus years that I've been gone. So grateful to be here with you today, and happy to be giving an update about what's happening in ODDS. I do also just want to recognize and acknowledge the passing of Ruth. I worked with Ruth when I was in ODHS the first time back in the early 2000s, and she was just an amazing human being and a really powerful advocate, and really left a huge impact on the system. And so she's going to be greatly missed. Obviously, this is my first time coming in, presenting, and being in space with all of you. And I have a list of a few things that I can update you on about what's happening within ODDS. There's probably a much longer list, but I know I only have a short amount of time. So we've been working through the past several years on the ARPA funding. I'm assuming that you all have heard about all of the ARPA funding that came in through the pandemic relief, and the really significant investment the federal government has made in really shoring up home and community-based services. And so we are starting to wind down our ARPA project, all of the funding for ARPA, and that's across ODDS, Aging and People with Disabilities and also the Oregon Health Authority. Those funds have to be expended by March 31st, 2025. And then we'll be closing out the projects that we have been undertaking as a result of receiving that funding. And as part of that, what DD has done is they have been in the process of implementing their Oregon Needs Assessment, which is the functional needs assessment tool and institutional level of care tool for people with developmental and intellectual disabilities. As part of that change, we have realigned our in-home services into service groups based on acuity and need of individual. And as part of the ARPA requirements, the state was unable during that, or prohibited actually during that time, from reducing, suspending, or denying services or eligibility or rates to providers. And so on March 31st, 2025, when the maintenance of effort and the ARPA funding stops, we will be implementing our full Oregon Needs Assessment to include these new service groups for in-home recipients based on their needs. And so we've been doing a lot of planning on how that's going to work out. We are anticipating that about half of the individuals receiving in-home services will not be impacted by this change, and the other 50% may experience a reduction in service hours based on their new service group. So we are going to be doing a rolling implementation of that new service group method, and that will take about a year to do. We are going to do new assessments and updating service plans during their annual service plan development process. So we didn't want to do a big cliff, basically, or a big transition to this new service group and have a lot of issues for the people that we serve, and also for our Office of Administrative Hearings, because individuals who will be experiencing any sort of reduction in service hours will have the opportunity to file an appeal and ask for a hearing. So that is a big chunk of work that we have coming before us. We're doing the best we can to minimize the impact on the individuals that we serve. And part of that is really also looking at our Oregon Needs Assessment. The tool has been in effect across ODDS for more than 5 years now, but we are just now moving into the in-home service hour area. But we've learned a lot in the last 5 years, and we've heard a lot of feedback from folks about areas where the assessment tool may not take into account specific needs, like nighttime needs and behavioral needs and things like that. So we'll be doing some reviewing and potential modifications to the tool to make sure we're capturing needs appropriately, and so that people aren't also experiencing any sort of reduction that they shouldn't be experiencing based on their assessed needs. So I'll pause there and see if there are any questions on that piece. That was a lot of information, but really felt that you all would be very interested in that as it relates to in-home services.
Hi, Dana. This is Commissioner Adams.
Hi, Commissioner Adams.
I do have a concern.
Okay.
With the structure that you're proposing, or at least working on. My concern is in two areas. One is us commissioners has been working very hard in getting the workforce in for state providers and affecting them. Second of all, my other concern is people that are para and quads. I'm hoping that they're not going to get affected too hard, because they really need the service. And if they have nobody that's going to help them, then there's going to be a sharp decline in that disability community like that, for more of a depression, them feeling like they can't be a human being. So when these changes do take place, I'm hoping that that is be taken into consideration.
Absolutely. I appreciate that comment and agree with you 100%. Part of the process is, so this isn't something that's going to just start rolling out on March 31st. We've been sort of ramping up to this for the last year and a half. And so we've been applying the old assessment tool and the ONA when we are doing needs assessments on individuals. And if there's a marked difference in the number of hours that individuals are assessed as needing, we're having conversations with them at the case management level and saying, okay, does this adequately meet your needs? Are there things that we're not taking into account, such as what you had just mentioned regarding depression and being able to participate in community, et cetera? And we have been issuing exceptions for additional hours in those circumstances. So that's those exceptions will also be in place for longer periods of time. I believe it's up to 5 years for adults, and I believe it's 3 years for children. We also don't want to be in a position, though, where we have an assessment tool that isn't accurately capturing the needs of individuals, and we're having to do lots of different exceptions to make sure that the needs are being met. So that's part of the work that we're trying to do on the back end as well, on the assessment tool itself. But there are options. There are definitely case management, choice counseling, et cetera, and the requests for exceptions in those circumstances. Absolutely do not want people to be harmed in any way or have their lives impacted negatively. And as you were saying about the workforce and how that impacts the workforce, that absolutely is a consideration as well. We know that we're in a workforce shortage. We don't have enough in-home care providers to meet the demand. And we need to make sure that, you know, while we're doing the work on right-sizing assessments and assuring folks are getting what they need, we have to have an adequate workforce to meet those needs as well. So it's kind of a balancing act, and you know, we just have to be really nimble and be able to adapt when community is telling us that things aren't working appropriately, and also when we're hearing from providers that, you know, we're spread thin. We don't have enough of us to be able to meet the needs. So I appreciate you bringing that up, and I'm happy to come back again and provide updates on what we're seeing, provide information on the number of exceptions that we have approved through this process, and really what we're seeing as we move this out. I think we're going to learn a lot.
I would like that idea, and I'm pretty sure the other commissioners probably feel the same way. That way, because like I said, we're working hard in building working to build the state provider idea. And the more that we can get in on the workforce, the better that it's going to help people that are really in need.
I agree.
Dana, this is Commissioner Wenzel.
Hi, Commissioner Wenzel.
Hi. I'm wondering if you're at a level where you might be able to share your new scale of evaluation, if that's possible.
Oh, you'd like a copy of the tool?
Yes.
Oh, I'm sure we can provide that. Happy to do that.
And I'm wondering if when you reduce hours because you are you joining these people or connecting them with other agencies or services or their school to meet some of these needs that you will not in the newer evaluation?
That's also a very great question. I'll need to loop back with our team about the outreach that has been done with schools. And of course, you know, there's again, the balancing act of Medicaid funded services and what we can provide through that that program versus what schools are required to provide as part of a free and appropriate public education under the education rules and regulations. We'll need to look into that. Again,
Mhm.
the goal absolutely is that people are not doing without, that their needs are being met. If the way that the service hours are working is that it's a range of hours. There's a minimum number of hours in a service group and a maximum number of hours in a service group. There are
Mhm.
5 different service groups. And so, for example, I'll make this up because I don't know the exact numbers off the top of my head, but in a service group, for example, 3, the minimum number of hours an individual may be assessed as needing is 200 hours per month. And the maximum number of hours, for example, could be 300 hours per month. And based on how the individual sets up their service plan with their ISP team and works with their providers, they have the flexibility to be able to determine the hours of the day that they want coverage or want the individual service provider there. It's really customized based on the needs of the individual within that service group allotment. But again, if there is a circumstance where an individual says 200 hours a month or 300 hours maximum a month is not going to meet my need, I need 350 hours per month. We've been doing a lot of work up front with them before this change takes effect to get those exceptions in place so that they're not experiencing a reduction.
Very good. And I have one other question. I've been reading that Centers for Medicare Medicaid are requiring that only fully licensed mental health counselors be used and not ones that are in training. And there may be a great shortage of licensed counselors. This will have a deleterious effect on the whole world, really. And have you been thinking about this with your program?
Truth be told, I think about the gaps in the mental health, behavioral health system and all of our individuals all the time, because I think there's a huge unmet need for folks who are receiving home and community-based services to get the mental health or even substance use disorder treatments that they need, because we do have just such a vast shortage. I'm not sure that I've seen the Centers for Medicare and Medicaid Services directives or releases on that. I do know that Oregon Health Authority is requiring that they're doing some rule changes. They're requiring that any qualified mental health associate is operating under the supervision of licensed I'm sorry, I'm trying to get all of the acronyms correct. Qualified mental health professional, which is a different level of credentialing. They're requiring that the mental health associates are under the supervision of the mental health professionals in a community mental health program, rather than the mental health associates being able to provide services in a private setting. So if I had for example, a license as a counselor, I would have to do my initial services, my training, my supervision hours under a qualified mental health professional at a community mental health program before I would be able to hang up my own shingle and be a private provider under the Medicaid system. And I know that there are concerns in the behavioral health community about how that's going to impact the number of professionals and clinicians available because again, we do know that we have a shortage of mental health professionals to treat folks and meet their needs. And then on the other hand, there's the concern that if you have inexperienced mental health professionals providing treatment or therapy, that can cause harm as well. Again, the balance, what's the right thing to do in terms of assuring that there's appropriate network capacity and quality of providers and services. So I know that they're also doing a lot of work in OHA on the workforce development of the mental health providers and substance use disorder providers. That's been ongoing, and they're also really looking at administrative issues that may be preventing folks from wanting to come into the industry and be mental health professionals in Oregon, whether it's licensing issues, contracting issues with our Medicaid program, et cetera. So lots of attention and lots of work being done on that. And I think we, quite frankly, have a long way to go. Because as I've experienced in both roles now, you know, we have an issue with a shortage of mental health providers just for the broader public. But when you are talking about folks who are experiencing developmental or intellectual disabilities, it's even tougher. And the same goes for individuals who are aged or have physical disabilities. It just makes things much more difficult for them to be able to access those treatments as well, and those providers. So lots to do there.
Thank you very much. We wish you strength as you plow through all of this.
I'm sorry, I didn't hear that last part.
Oh, we wish you strength as you plow through all of this.
Thank you. I appreciate that. I think if we all come together and work together, we can definitely make a difference. But we've got to break down some of these silos that we're operating in as well, and that goes across our programs in ODHS and our partners in OHA as well.
Dana, this is Commissioner Adams again. A question to with the idea that your department is wanting to do, is that going to back up the home care agencies and nursing homes too as well? Because of how you guys are structuring the hours and stuff come March?
It really should not impact the nursing facilities and the long-term care facilities. Where the impacts will be seen is really in our in-home program. We serve children and adults in their own homes, and we have sort of a different structure within ODDS. We do have personal support workers that are union represented that provide in-home services to individuals. And we also have licensed and certified in-home care agencies that ODDS actually licenses and certifies. And what we've been seeing in the workforce, which is, you know, we're trying to wrap our arms around that as well, is a shift from personal support workers over into the direct support professional space in the agency providers. And that's for a number of reasons related to the wages that the agencies are paying, the benefits that they're providing, the level of supervision that the agencies are providing to the direct support professionals. But I'm not sure if you all have seen the news. I'm sure you have, about one of our what's called standard model agencies, or River Grant. That's one of our in-home care agencies that is supposed to provide a higher level of service, administrative service for the direct support professionals delivering in-home services. And what we're learning is we've set up a lot of checks and balances as providers are coming in and applying to be these provider types, but we don't have as much depth on the back end to do the auditing of these providers to assure that the services that they're being paid to deliver are actually occurring. So we're taking a look at how we've structured the process to be a qualified provider in the Medicaid ODDS program, and then what we need to do the auditing and shoring up on the back end so that we're not in a situation where we're paying millions and millions and millions and millions and millions of dollars in taxpayer funding to agencies that may not be meeting the need or providing the services that we are expecting them to provide. So long story long, I have a tendency to be very verbose, apologies, but individuals with intellectual and developmental disabilities are not often served in nursing facilities. They have to go through a process by which they're assessed as needing that level of support. And if they don't need that level of support through this program, this process that's federally mandated, then they don't go into nursing facilities. And if they're in there for any length of time, they have to go through this process again to assure that that's the appropriate placement for them. We are seeing more and more folks, though, coming into ODDS from the behavioral health space. Because there's not a lot of capacity in residential services or in-home services for folks experiencing mental illness who don't have an intellectual or developmental disability, or who may not be aged or have a physical disability. And so they're coming in to our 24-hour residential settings because of the types of services that are provided to individuals with intellectual or developmental disabilities. Related to behaviors is a little different, but it's still not mental health treatment. So there's a gap in what these folks are needing and what they're getting. And that's a real concerning issue.
I would love to have you come back and visit us another time soon and see what's happening.
I would love to come back anytime.
Thank you so much.
Before you leave, Dana, do you want to mention Brett Watkins' new role?
Thank you. Yes, I'm sorry. And Commissioner Johnson, I think, had his hand up as well.
Yeah, real quick. Hi, Dina. Thank you. Thanks for this helpful information. Just wanted to mention how grateful we are for the work that you folks do, and our desire on the commission to have your voice really strongly heard here, and just kind of reiterating our desire to see someone from ODDS representing you folks on the commission. It would be great to have a commissioner representing you. I don't think we currently do and have not for some time, and just putting that out there.
I appreciate that. Yeah, thank you. And Jenny and I actually spoke about that earlier. I'm sorry, Commissioner Wenzel, I didn't mean to cut you off.
Oh, no, I'm not. I was letting Paul speak. And so we thank you then for what you said today, and very, very informative. So thank you for visiting, and we have 2 other speakers waiting.
Absolutely.
So,
Marcia,
yes.
Is it okay if Dana talks about Brent Watkins is in his new role? I think you'd be interested in that.
Yes, sorry, I forgot that. Go ahead, Dana.
No, that's quite all right. Thank you. And this goes right into what Commissioner Johnson was saying regarding DD representation. I know Leslie Sutton, the previous executive director of the Oregon Council on Developmental Disabilities, has been here before. Leslie has taken on a new role with the she's the residential facility ombudsperson with the long-term care ombudsman's office now. And we have Brett Watkins, who is a longtime ODDS manager, filling in as the interim executive director of the DD Council. We also have a new chair of the Oregon Council on Developmental Disabilities, and that individual is just stepping into the role, but is a self-advocate, which is incredible. I think that's absolutely fantastic that a self-advocate is going to be leading the DD Council. And with the changes that are being made to the council, I think that there's absolutely opportunity not only for us to have representation on the commission, but also for us to partner and build across, so that we have strong collaboration as well with the council and the commission. So that's some good news there, I think.
Very good. Okay.
All right.
All
Thank
right.
you all. Happy New Year.
You too.
Appreciate the opportunity to visit. Take care.
All right. Bye now.
Bye-bye.
So Jenny,
You mean any what?
I'm in the meeting. Oh, Jenny,
Yes.
we have the young adults, the two reps from that. And then are we going to get this done? And Jane Ellen, is she going to be thrown off time? Should we juggle some things? What do we do?
I'm sorry, Marcia, I wasn't able to hear everything. So we have a presentation at 11, and then I heard you say Jane Ellen, and she's at 11:30, I believe.
Yes.
Okay. It looks like our guests are not yet here. So you have 5 minutes. You might want to go back to the we can either do public testimony or the update from all the commissioners on their projects.
Oh, 5 minutes, public testimony.
Okay, we do have public testimony. And let me bring that up and I'll read that. Okay, begin testimony. Full disclosure, I am an SCIU Local 503 Board Director, Home Care Council Director, and Home Care Bargaining Team member. I am not speaking for the union in any capacity. Urgent matters requiring immediate OHCC response. The questions raised in this testimony are not rhetorical and demand direct answers from the OHCC during this meeting. These issues are critical to worker safety, fairness, and overall system functionality. Action is required now to address the following. 1. Premises inspection for safety. Before workers are sent into consumer employers' premises, these locations must be inspected to ensure they are safe. Additionally, there needs to be a clear protocol for workers who feel unsafe. This is a foundational issue of worker protection. OHCC must provide a solution during this meeting. 2. Emergency protocols for natural disasters. In December 2024, the Southwest Coast faced a tsunami warning, leading to evacuation in some towns. What is the protocol when a consumer employer refuses to evacuate? Workers need clear guidance in such emergencies to avoid placing themselves at risk. OHCC must address this today. 3. Recognition of long-term services. The current contract fails to recognize workers with over a decade of service, leaving many older workers, earning less than newer hires with fewer years of experience. This inequity is a direct insult to long-term workers and must be corrected. The excuse of missing records is unacceptable. OHCC knows when provider numbers were issued. Implementing a simple step increase of 10 cents per year of service would resolve this. OHCC needs to commit to correcting this inequity now. 4. Worker referrals and Carina issues. Carina is failing to help workers secure referrals, while agencies dominate the majority of consumer assignments. DHS offices should maintain and share worker availability lists as they did before Carina. What will OHCC do to ensure workers can find referrals? 5. 24/7 emergency contact for workers. Workers urgently need a 24/7 emergency contact line. Without it, new workers, especially those facing crises outside business hours, are left unsupported. The gap poses serious risks. What step is OHCC taking to establish a 24/7 emergency contact system? 6. Gap pay for hospitalized consumers. When a consumer is hospitalized for an extended period, workers lose income. This leaves workers in financial jeopardy through no fault of their own. Bargaining over this issue does not resolve the immediate need. What is OHCC prepared to do to address gap pay now? These are not abstract concerns. They are immediate challenges that demand concrete solutions during this meeting. Workers are watching and expecting action. Time is of the essence. Now that the OHCC and DHS have been made aware of their shortcomings and failures in a public meeting, they cannot take the position they did not know. Testimony respectfully submitted by Avery T. Horton Jr., home care worker, citizen, voter, taxpayer, state of Oregon, as always acting in individual capacity. End of testimony. I know that Mr. Horton would like some concrete actions, but unfortunately we are not able to provide those today. I will address some of the issues. So premises inspection for safety. I want to remind everyone that the place of employment is an individual's home, and they're able to have that home, in a way that reflects their individuality and safety, and they get to choose their home, what their home looks like, and how things happen in their home. So if during an assessment, a case manager notices various issues that may be correctable, that ensure safety, like maybe there's a throw rug that's not safe, or maybe there's rotting floorboards in the home, that they can talk about that together and what kind of resources are available to remedy some of those things. If an individual provider feels that they are unsafe in that home, there is a way for them to report that issue. We do have a way on our Oregon Home Care Commission website to report health and safety concerns that a provider is experiencing, and we would encourage them to do that anytime somebody feels unsafe. And then the commission follows up with that provider and also the local office. So I would encourage providers to follow that process. And I would invite the commissioners also to offer feedback about their homes and their homes being inspected. Emergency protocols for natural disasters. I do not know what the protocol is when a consumer employer refuses to evacuate. They have the right to do that. We do not expect workers to stay in an unsafe situation. So if somebody should be evacuating and the consumer employer does not want to, we would not expect a worker to stay in that unsafe situation. This would be a policy decision, but my thought would be to let emergency responders know that this person is staying at home and that they would be without a caregiver in that situation. We would never want providers to stay in an unsafe situation, nor do we want consumers to be in an unsafe situation. Recognition of long-term service workers. This is a bargaining issue. So anything related to pay or benefits would go through the bargaining process. Worker referrals and Carina issues. I've said multiple times that it was never the intent for local offices to give out independent lists of available home care workers. That is not what either registry is intended to do. It's a matching system based on the specific needs of the individual needing assistance. So we have never supported lists of caregivers. The commission has not supported that. 24/7 emergency contact for workers. We do not have a 24/7 emergency contact line. We are not staffed for that. That's not in our purview in statute to provide 24-hour emergency contact line. What I would like to say about this is if there is an emergency, providers and consumers should definitely be using 911. If it's an issue where a provider is not able to report to work, that's something that they need to have a conversation with the consumer employer about. And, that would be one of the conditions of employment, is having discussions about what happens when a provider is not able to show up for work. Case managers also talk to consumer employers about backup plans. What happens if a worker is not able to report to work, or if there's a natural disaster or some other emergency in the home. If emergency care, urgent care is required because something is happening with the consumer employer and the worker needs to work more hours, there is provisions in the collective bargaining agreement to allow that, and then they are responsible, the provider is responsible to contact the case manager within 2 business days to report that. Gap pay for hospitalized consumers. Again, any benefit to pay for providers when individuals are hospitalized would be a bargaining issue. And that's my response. I don't know if the commissioners would like to offer any response as well.
This is Commissioner Adams. On some of these are already been put into place. And I'll give you an example. As far as a consumer being hospitalized and the caregiver is with the consumer, it has already been written in by Mike before he retired, before Nikisha took place. Mike had this thing set up where caregivers were there for their consumers in the hospital because there was a concern that when the hospital people didn't know anything about the consumer, the state provider knew more about the consumer than the hospital did. So then, and it's written on a thing that Mike did and got approved, I believe, to the legislature before he got retired. If I'm not mistaken, I think they also get paid for being there with the consumer for their needs when the hospital don't know nothing about the consumer's needs. And I will agree with you, Jenny, about the consumer workplace. That there will be very hard to enforce because each consumer will have their own setup. There would be a lot of fight with that because the consumer will feel like they're not being treated as an individual, so on and so forth. And what was the other ones you said?
Let me look, George. Emergency protocols for natural disasters, recognition of long-term service workers, worker referrals and Karina issues, 24/7 emergency contact for workers, and gap pay for hospitalized consumers.
Okay, for the consumers, there is a thing set up that's in Portland, and they check on their consumers all the time to make sure they've got the right phone numbers on the right locations when it comes to disasters. It's called the disaster registry. The caregivers can go with them whenever there's a disaster because it's on the, I believe it's on the disaster registry. I get called in all the time to make sure my information is right, whether it's local or a cell phone or a whole 9 yards. Also, they will ask me what location is already set up for me in case there's a disaster. So that should be done for all consumers. State of Oregon. It's done either, I believe it's every 3 months or every 2 months, I think. That's
George? Yeah, sorry to interrupt you, Marcia. Is that just for Portland Metro or is it for the state?
That's for the whole state of Oregon.
Could you send the contact information for them? That would be very helpful.
I can get a hold of Rogue Valley Council Governments, that information, and have it sent to Jenny so that Jenny can be sent to you.
Great.
Marcia, we do have our guest speakers here.
All right. Okay. So then I guess we can move along. And we have 2 gentlemen that are from, just took the screen off. Sorry. From young adults with special health care needs, Ty and Max. Would you please introduce yourself and tell us more about what you participated in? Thank you so much. I see a PowerPoint.
Yeah, thank you, everyone. Hi, my name is Max Brennan-Court, pronounce he, him. I am the policy lead for this program that I'm going to tell you about, which is a Medicaid benefit titled Young Adults with Special Healthcare Needs, and I'll tell you a little bit more about it. I'm accompanied here with my colleague, Ty Schwafferman, who will just be in the background for now. And we can take questions throughout the presentation and at the end if that works. I got started a little bit at the beginning because I thought I was going to be sharing the screen, but I'm happy that you're doing it. So I'll just say next whenever I'm ready to move to the next one. And I'm ready now. Next, please. So before introducing the WISHIN program, it's an interesting acronym, but it means what I just said, young adults with special healthcare needs. I'll talk briefly about the Oregon 1115 Medicaid waiver, which started the process for this particular program. Talk about WISHIN itself, then how it relates to two other very important program in one case and standard of care in another one. So the standard of care is the early and periodic screening, diagnostic, and treatment, also known as EPSDT, kind of acronym soup. Then talk about health-related social needs, HRSN, and then do an overview of what this program means for community members and young adults in the state, and then take questions. I know it says questions and answer at the end, but I'm happy to take questions either in the chat or if you want to interrupt me, I also do not mind. Sorry, I'm paying attention to the chat. I don't know that this is for me, but if you have questions, either way works for me. I'll go next. So yeah, the background for this program is because it's nested in the 1115 Medicaid waiver. I'll go next. You may know about it, but if you do not, of course, Medicaid work, Medicaid is structured in a certain way. Every state manages their own Medicaid program. And in Oregon, our Medicaid program is administered under the Oregon Health Plan, OHP. OHP is free healthcare coverage for folks who are low income, children, teens, and adults who live below a certain income threshold in Oregon. And yeah, you can apply every year for those who have a need for that. I'll go next. So the Medicaid waiver is, as I mentioned, states administer their Medicaid programs, and some of it is directed by federal rules, some of it is directed by state rules. And states, to keep their Medicaid funding, need to ask or request to change their programs if they want to administer it in a way that is not codified. And these changes for us at Medicaid, they're called Medicaid waivers, and the 1115 waiver is one of them. I'll go next. So yeah, the Oregon 1115 Medicaid two years of continuous enrollment for OHP members who are 6 and older. I'm getting a message that my connection is unstable, so if I'm breaking up, please let me know, interrupt me. I'm happy to start again, but I hope I'm okay. I hope you can still hear me. So coverage for HRSN, health-related social needs, is under this waiver as well. And we also have coverage for a limited set of services for folks who are exiting the carceral setting. And then Waishin, my program for young adults.
Max, you're frozen. We're not able to hear you. It might be worth turning off your camera. Max, were you able to hear me?
Now I do, yes.
Okay. You keep freezing. You may want to turn off your camera and see if that helps.
All right, thank you for letting me know. I'm ready to go next if you can hear me. So yeah, go next again. So happy to talk to you about the Waishin program itself. So Waishin is this new Medicaid eligibility category. So folks get an opportunity to qualify for the Oregon Health Plan. It started yesterday. So it's a brand new program, which is why you may not have heard about it before. It will offer more benefits to young adults with qualifying conditions, and I'm happy to tell you about them. I'll go next. So just some background to understand why it's important that Medicaid offers additional benefits um, for this category of individuals is that in Oregon, 1 in 5 children under the age of 18 has a special health care need. And folks with those needs have higher health and health-related social needs and the waiver, the 1115 waiver gives Waishin members extra time to transition from pediatric level coverage to adult level coverage within their Oregon Health Plan enrollment. I'll go next. So Waishin members are, because it started yesterday, or will be young adults who are between the ages of 19 and 25, and they live with a health need that results from either a physical, intellectual, or developmental disability, some sort of long-standing medical condition, or a mental health condition, substance use, or neurodevelopmental condition. I'll go next. So to qualify for this program, these young adults would have to be at or below what is considered 205% of the federal poverty limit. And this table sort of tells you in numbers for which family size, what income does it mean? What monthly income would qualify at or under that level? I won't list them, but you can have a look. And I'm happy to share this presentation to folks as well if you would like me to send it again. I'll go next. So in 2025, so this program is being implemented on a rolling basis. So this year, right, 19 and 20-year-olds are eligible to enroll. And then once enrolled, folks keep their benefits until they turn 26, and their eligibility is reassessed every 2 years. Independent of changes in circumstances. So once they qualify, if an individual is 19 or 20 this year, they will be reassessed in 2 years, and they can keep their benefits until they turn 26. I'll go next. So this is a little compare and contrast as to what used to be the case before yesterday and how Waishin makes a difference. So before 2025, Folks on OHP would get this level of coverage if they were at or below 138% of the federal poverty level. I don't have exact numbers, but just imagine that that table would have lower numbers to qualify for this level of coverage. They would get early and periodic screening, diagnostic, and treatment coverage, which means basically comprehensive health care, and enhanced vision and dental benefits that would end once they turn 21. So the difference that Weishin makes on the right-hand side is that the allowable income for this level of coverage has increased to 205% of FPL, and EPSDT coverage, enhanced vision and dental benefits, now end at 26 instead of ending at 21. So we're allowing more folks to have this level of coverage, and they keep it for much longer. I'll go next. This is to describe how we're rolling out this program to different age groups over the years. If you noticed, I started this presentation by saying that Weishin members are between the ages of 19 and 26. Currently, that full age bracket is not able to enroll yet. This year, as you can see in 2025, only 19 and 20-year-olds will be able to enroll, and of course, keep that coverage until they turn 26. And then every year, we're going to increase that upper age limit by 1 year until full implementation. Obviously, this will take a while. It will be by 2030 and beyond that. For example, a 25-year-old will be able to enroll in this program. But every year, basically, we're going to allow more folks to get this benefit and keep that benefit until they turn 26. I hope that made sense, but I'll go next for now. So just to explain what EPSDT is,
Alrighty.
it's,
You okay?
yeah, I think, yeah, we can hear somebody's microphone, but okay, I hope you can hear me. Yeah, just to introduce early and periodic screening, diagnostic, and treatment, also known as EPSDT. I'll go next. So it's a federally required benefit. It's more a level of coverage instead of benefit, but it is the fact that in Oregon we provide complete healthcare services for children and youth under the age of 21 who are enrolled in Medicaid or in the Oregon Health Plan. And this is independent of any prioritized list of conditions and treatments. Starting this year, Weishin members will also get that comprehensive level of coverage, and they keep it until they turn 26. So for folks enrolled in Weishin, they keep comprehensive health coverage for longer. I'll go next. What does EPSDT require? Well, it's for all medical services to be provided and covered by Medicaid if they're necessary and appropriate. So by medically necessary, we mean that a treatment is required to prevent, diagnose, or treat a condition or to support growth, development, and participation in school or work. And medically appropriate just means that the treatment is safe and effective. It used to be the case that for anyone under 21, EPSDT would cover all of this, and that age bracket with Weishin has just increased a little bit. I'll go next. So just to talk about health-related social needs, HRSN next. You may know about this. I know a lot of folks in Oregon have at least heard that acronym. OHP obviously also offers some members HRSN benefits if they have a demonstrated need, and Weishin members are eligible to be screened for HRSN benefits, which means that they get an opportunity to say if they have a health related social need that needs to be covered, and it will be covered if they demonstrate it. And HSN benefits include housing support, nutrition support, equipment to stay healthy during extreme weather, as well as some degree of outreach and engagement. I'll go next. So next one as well. So changes for community members. Well, starting this year, right, 4,700 new young adults may qualify for OHP benefits as long as they go through the one online system and fill out an application and get their determination of being a WISHIN member in Oregon. I've seen the reports. There's already over 16,000 OHP members from 2024 who sort of either retain their benefits or just received higher level coverage for their services because they're WISHIN, and over 2,500 individuals may qualify because of an intellectual or developmental disability. And ODDS, the Oregon Department of Developmental Services, I think is the acronym, supports us in identifying those members and providing that level of coverage. So it's just important for caregivers, community providers, community health workers, social workers, anybody who interacts professionally and personally with young adults to know about this and tell them that this is an option that's available. I'll go next. So I'll go next as well. So we identify young adults in a few ways. So in 2025, like I said, somebody who's 19 or 20 has the opportunity to enroll if they're at or under 205% of the federal poverty level of income. And they can either demonstrate that they have a complex chronic medical condition from their medical history, attest to having a mental health condition, substance use disorder, or neurodevelopmental condition, or if they have an intellectual or developmental disability identified through ODDS. This information is provided to one online, which gets to enroll folks if they qualify as WISHIN. And then for new OHP applicants, they would go through that fourth pathway, which is determination of an elevated service need identified through a WISHIN eligibility screening questionnaire. So I'll go next. So that questionnaire, the way it works is that it's administered through either the one online system or the OHP paper application, which is available in multiple languages. It's been developed with a partner of the Oregon Health Authority called OCEAN, the Oregon Center for Children and Youth with Special Health Needs. It's quite a mouthful. And it's really 6 questions where if folks answer positive to 2 of the 6 questions and they meet the other requirements, they get enrolled as WISHIN because they would be deemed a young adult with special healthcare needs. I'll go next. So this was the general intro to the program. Sorry, my internet was glitching a little bit. It seems like some days it does that. I'm happy to hear from you, and then I'm also happy to show you the resources that are linked here. You can go next. Let me know if you have any questions. Happy to answer if it wasn't clear. And send additional resources as needed. Any questions you have?
Yeah, Max, this is Commissioner Adams. I was in the HRSN meeting and also the HERC meeting, and it was told that the Medicaid waiver was going to end in 2027, and they were going to, OHA was going to replace it with HERC, which means that anything that didn't get approved by CCOs that HERC on the committee was going to have to approve for services like spinal infusions and some other stuff. Is that true?
So so if someone is enrolled in Weishan, right, and they're getting OHP within this program, as long as they have a health need that is demonstrated to be medically necessary and or appropriate, they would receive that service under this program, independent of who makes the final approval decision. I hope that makes sense.
Sorta. I'm still trying to make sense of it.
So what I didn't answer, and I'm gonna acknowledge it, is how that decision pathway is laid out and or will be changing. The waiver obviously goes until September 2027. Within the Weishan world, it is our hope that the waiver will be either extended or renewed. Obviously, this is executive level leadership, decision-making power. I can't make a promise that it will go one way or another, but at Weishan, we are planning as if this program is going to go beyond 2027, and budget has been allocated to it, keeping that in consideration. So this is some additional tidbits. I don't know that I'm definitive in my answer, but I hope this is helping a little bit. And let me know if you want me to clarify anything. I'm happy to take other questions or more comments.
Yeah. Hello, this is Commissioner Wenzel. I was hoping you'd be able to share your PowerPoint with us.
Yep.
And would we have permission? You encouraged us to share this information with others. May we share the PowerPoint, which explains it in a very clear fashion? Is that possible?
Yeah, I'm going to ask my colleague Ty to communicate this PowerPoint to the group once I am done with this presentation. And yes, feel free to share it out with whoever needs to hear about it. This is a new program, so a lot of folks may not have heard about it or may have additional questions or may want to have material to distribute, and we definitely want this to be one of those.
Okay.
Excuse me, Commissioner Wenzel, we did get this yesterday late, so between Jenny or I, we could get it out. Okay?
Oh, great. Another question. In elementary school, when children are having difficulty with language skills, reading, not all of them are tested to see exactly where the problem is, because there's a lack of funding. They only take a small number, and they have to be evaluated by a licensed clinical therapist, and they only get, I spoke with one a couple of years ago, they only get paid $60 per evaluation, which requires hours upon hours. And so very few licensed clinicians want to participate. I think it's the root cause of many people failing at school. Is that the difficulties in school that could be a language disability? Are they counted towards benefits in this program?
So yeah, if it's a permanent disability, it would seem to be a qualifying condition. I think the simplest way for folks to know if they qualify for this is to go to one online or fill out a paper application, and with that information, we can make a determination. Yeah, I think that's the best advice to give folks. For folks who are already current OHP members, if they meet the qualification criteria, they will be automatically enrolled and be notified that they have been enrolled, and they will get those benefits as applicable. So for folks who are currently OHP members, it'll be a very, very simple process. And then for new applicants, going through either the online portal or the paper application would really help set them up for success.
Okay. Well, for your thought, my question was mainly about if you don't know because that you have a permanent language disability, let's say, because you haven't been tested, will this broaden in any way the opportunity to get a diagnosis and then remediation? And I'm a previous school teacher. I feel that it would produce more people that were able to complete a school program than currently happens. So it's a sweet spot for me. But you may not have an answer now. Another time, if you come to visit us, maybe you will.
Folks who do not have a formal diagnosis also can attest to their needs and get qualified that way. So I just want to say that very quickly and leave it there. So I had mentioned the one portal because that determination would be through that questionnaire that we administer. So we ask folks either if they live with or if they're at risk for certain conditions. I hope that helps. I'll go next to just show folks what's awesome. Thank you. I'm afraid I may be running out of time, but I just wanted to show you, we have a Weishan webpage listed here for folks who will get the presentation. We have a 2-pager available for CCOs and open card providers. And if you have questions, the email listed here is the best place to get started on getting an answer. I think there's one more page with other resources. And these are pages for EPSDT to understand what it is, health-related social needs to understand what it is, and 1115 waiver for folks who are curious about it as well. I thank you for your time. I'm happy to take a couple more questions, but you might end up telling me that I'm out of time. So happy to take questions. Otherwise, thank you for your time today.
Max, this is
Yes.
Commissioner Adams real quick. With what you're doing, is this going to mess up the one system committee that I'm on? When people are applying for services for medical wage stamps and state services?
I don't believe so because we went through an extensive process of redesigning one, and it takes into account how Weishan interacts with the other programs. Weishan will only apply to folks who do not qualify for a higher level of coverage elsewhere. So I just wanted to reassure folks that if they qualify for higher benefits elsewhere, they will get it, right? And Weishan will be a supplement. And if they don't qualify for other programs, Weishan will be their primary way of getting the care that they need.
Okay.
Thank you so much.
Awesome. Thank you for your time. Happy to send additional materials if needed or required. Otherwise, it was great, great conversation. I really appreciate the questions as well. Thank you so much.
Okay. Goodbye for now.
Bye.
I see Jane Ellen Weingatz waiting for her slot. And Jenny?
Yes, Jane
Yes.
Ellen is here.
Yes. Oh, the people from the university.
No, I'm sorry. Jane Ellen is speaking first, and then our guest speakers from the university are at 12:30.
12:30. All right. Jane Ellen.
Hello, everybody. I just want to take a minute and actually, in case anyone doesn't know me, Jane Ellen Weingatz, she, her pronouns, Deputy Director of Policy for the Office of Aging and People with Disabilities. Just want to take a moment to acknowledge the huge loss to Oregon with Ruth McEwen's passing. I'm sure you guys have discussed that, and I personally have known Ruth for okay, I'm counting the years, almost 30 years, and I have always so admired the work that she has done and the advocacy that she has done. And it's just a huge loss. And just can't even express how devastated I think that I am, and I think the APD leadership is as well, just because she's been such an integral part of our system. So I want to take that moment and say that, and then start my presentation. And being Jane Ellen, I am doing things at the last minute. So I'm going to pull up a PowerPoint that I have not sent to Heidi. And then, but I will. And I'm going to share my screen, maybe. Share screen. Can you see my screen yet?
Yes.
Yay. Okay, so I'm going to do a quick update from APD Senior Exec. And we use that term a lot, and I just express that under Nikisha's leadership, that Senior Exec is really the deputies and Nikisha. So it's Nikisha Knight-Coyle as the director, Erica Miller as our operations deputy, Carissa Neufeld, sorry, got confused there. Carissa Neufeld as our safety and oversight and deputy, and then me as the policy person. So we kind of make up that core team, and this is kind of the things that we are working on right now. Really, a lot of it is getting ready for legislative session. So we know, so I'm going to go through the governor's recommended budget. I'm going to give a quick update on agency with choice, and then Oregon Project Independence Medicaid. And then I'll kind of throw in some other stuff as well. So the governor's recommended budget actually was not as bad as we were afraid it could be. We didn't get everything we wanted, but we came out of it with no deep cuts into our program and some wonderful investments. The first one is what we're calling the Access Policy Option Package. So as a reminder, policy option packages are requests to the legislature to fund something new. So we have our current service level. What are we going to do next biennium to serve the people we're currently serving? And that's caseload driven, number of people we're serving, multiplied by the average cost per case. There's your budget. And so current service level was fully funded, and then we have some additional access policy option packages that are those requests for additional funding. And one of those really critical to us, and these are not in order, by the way, but the access POP, we've talked a little bit about this, is that CMS has strengthened regulations around access to home and community-based services that will have dramatic change on how we do our business. And I've highlighted some of those in past discussions, and happy to come back and talk about those. The timeline starts in 2026 and then goes through 2030. And so we have time to do things, but these are massive changes to our assessment, changes to our service planning, changes to our grievance system, changes to our critical incident work, right? So massive changes to our system. So what we asked for, and this is a highlight, oops, I forgot this slide was here. So in 2026, so the biennium, don't forget, is July 30th, 2025 through June 30th of 2027. And so what we're doing is really trying to prepare for the changes that were required in 26 and 27. And we need staff to do that. And here's just some of the highlights. So we have to create a new grievance process that we've never had before. This is different than the appeal process, if you've been denied or had a reduction in service, the grievance process is you don't like your case manager, you don't like your provider, you don't like something that has happened and you're grieving that. And we've never had a formal process for that. We're going to have to create public transparency on rates. We're in the process of new processes for public reporting on quality measures, and I mean massive changes to quality measures. So we currently assess people for individuals within their instrumental activities of daily living and instrumental activities of daily living, and that drives the service plan. We're now going to need to change that and add in a whole bunch of things like social isolation assessment, a suicide ideation assessment, a home assessment in fall risks, a whole bunch of different things that are included. That, and I'll share that. Yeah, I'll go ahead and share that with Heidi, and she can get it out to you, just so you can see the level of detail CMS is expecting in our new assessment process. And then,
Jane Ellen, will you please send that to me? Heidi's out today.
Oh, yes, happy to. Thank you. So then we also need to complete a consumer experience survey, which we currently do through what's called the National Core Indicators for Aging and People with Disabilities. And also need to track the more intensive person-centered service plans, tracking transitions to and from nursing facilities. So individuals coming in and out, and then the new assessment requirements that I just talked about. In 2027, we'll have to start reporting on wait lists for access to our waivers. And that not only includes access to, we've never had a wait list on the APD waiver. DD does on their model waivers, and they used to in their other program, but they don't anymore on their core program. But it's also a wait list of how long is it taking individuals to go from being determined eligible to actually receiving paid services and supports. And that's an issue I think we've talked about, that there's about anywhere between 5,000 and 7,000 people in the APD system that are eligible for services, but have, for one reason or another, been unable to find a paid caregiver. And we're working, and hopefully Jenny's updating you on some of the work that we're doing that to try to alleviate that backlog of people. But we're also going to have to report out publicly on heightened critical incident reporting, our intervention and mitigation. So critical incident is anything bad that happened to the people that we serve. And sometimes that's abuse, like they were supposed to have assistance getting from their wheelchair to their bed, and the caregiver didn't do it right, or they weren't there when they were supposed to be. And sometimes I always use the example of a fall, right? If an individual has been assessed as a fall risk and they're supposed to have someone there to help them, if they fall, that could be abuse or neglect. If no one was supposed to be there, like many of our in-home consumers don't have care 24/7. If no one was expected to be there, but they fell and got hurt and had to go to the emergency room, that's still a critical incident. And so we're going to have to strengthen that and publicly report out what that looks like, not on an individual basis, but on a system basis. And then timeliness of access, I mentioned, and then all of our services and all of our reporting are going to have to be on a accessible home and community-based care webpage. That includes the work that we're doing, the work that the Office of Developmental Disability Services does, and the work that the Oregon Health Authority does. And by 2027, we have to document that there's what they call payment adequacy for direct care workers, so that the money that we're paying to providers goes down to the direct care workers. Easy peasy for home care workers, PSWs, and personal care attendants, because the money that we're paying, 100% of that goes for the benefit of the individual. But we have less transparency for individuals providing services in adult foster homes and any of our licensed care settings. So the policy option package is giving us staff to do the work. And this is a joint policy option package with the Office of Developmental Disability Services. And across the programs, we're asking for 24 positions and calculated out as 16, a little bit more than 16 full-time equivalencies. And what that means, and the reason why that's a difference, is depending on when people come in, like we can hire 6 months into the biennium, that's 18 months. So they don't count as a full-time equivalency at that point. So throughout 25, 27 biennium, we'll be bringing staff in to help us meet these new federal requirements. I think I kind of hit this. I want to be really clear that we think this is a first step with all the changes we're going to be making. We think we are desperately in need of additional case managers to help us support the new work that case managers are going to have to do. So this is first step and a first investment to help us meet the expectations. The MED POP, I really should change this name. I think you guys all know that we don't serve individuals whose primary, we being APD, does not serve individuals whose primary driver of a need is a mental illness. And we've been doing that since the 1980s. And we have a process that is called MED because it's the mental emotional disorder screening. And so we screen people out and we refer them to OHA to provide services. We should have changed that in 2013 when we went into the 1915K. We didn't change it, and now we're asking for us to be able to change that. And it's really critical because of all the people that APD denies, only 3% of those are being picked up by the Oregon Health Authority, even though they need ongoing support. So we're asking for specialized case managers who can help us work with individuals with mental illness, and then also special rates for providers to help us serve this population as best as we can. So that's the dollar figure there. We think it's really going to be critical. The risk if we don't get it funded is we have a potential of a federal lawsuit because we should be serving this population. And worse is, even worse than that, is that these individuals need our supports and they're not getting the supports that they're entitled to. So they have bad outcomes. And then our last POP is our strengthening regulatory oversight policy option package. I think you've probably heard us talk about this. We don't get into new facilities or adult foster homes in a timely way. It can take us 2 years to get into a new assisted living or residential care facility. And that's often when providers struggle, is in those first few months of providing services and supports. So what we want to do is provide more technical assistance, and we want to make sure that we are getting out there and making sure that these providers get into a good situation and can successfully meet the needs of the people that they're trying to serve. So we're asking for quite a bit of funding because we have a lot of facilities. There's over 500 assisted living facilities and residential care facilities. There's over 1,200 adult foster homes, and ownership and new ones are coming online. Ownership changes, then new ones come online every month. So this is another joint policy option package. The Office of Developmental and Disability Services has been doing this kind of work where they go out within 120 days and see these new providers. But they do it without the funding to do it. They've hired what's called a non-budgeted position to do it. And we want to get them out of that place where they have non-budgeted positions, and APD needs to start doing this. So that's kind of the budget. That we did have, and I forgot to mention that we had 2 kind of budget cuts or reductions. One is we have funded for a long time some early mental health early intervention for individuals with depression and anxiety who are not on Medicaid. And unfortunately, we haven't served a lot of individuals. And so the decision was made in the governor's recommended budget to use those funds to offset the MED POP and match it to Medicaid so we can serve more people, especially those individuals who are more impaired than the individuals being served in those senior mental health projects, so those prevention projects. The other thing that was taken is the Quality Care Fund, which is comprised of licensing fees and penalties and well, penalties for licensed care facilities go into the Quality Care Fund. And those funds are 18 million of those funds are being used to decrease the need for state general fund this biennium only for our safety and oversight team, and also helps offset where did the other 3 million go? Oh, the 5 million, sorry, 5 million of that is going to continue the training we do through the Oregon Care Partners, which was on our reduction list. So that's kind of the budget in its whole, in kind of what we're going into legislative session with. And the next steps on the governor's recommended budget is that we will be presenting to the Ways and Means Subcommittee on Human Services sometime probably in February. And it's an overview of what we do, how we do it, and what is in the governor's recommended budget. They will then continue to do some work and try to figure out how they're going to fund everything they want to fund, and address legislation that comes out of what's called the substantive committees. So committees that want to change policy or the law, those start in the substantive committees. They pass a bill, and if that bill has a fiscal impact, it goes to Ways and Means, and then Ways and Means decides to fund it or not. And if it doesn't come out of Ways and Means, it dies. If it comes out of Ways and Means, it is likely to be voted on by the full Senate and the full House, and likely becomes law. So all of that process will be occurring all the way throughout late January, all the way through the end of June, before we get our agency request budget. Back to agency with choice. I know that we've talked with you quite a bit about it. I just wanted to give you an update that we're on target to implement January 2026. There's been some requests to speed that up. And with the timeline that we have to meet with both brand new rules, brand new contracts, and state plan amendments, we don't think we can go any faster than what we're doing. We're in the Rule Advisory Committee process, and we think we're going to have 4 to 5 committees meetings, because these are brand new rules, and they're about 91 pages long. And they're long because we're licensing these new agency with choice providers to ensure that we can hold them accountable for any negative outcome that may occur. And we are also having to partner with the Oregon Health Authority to make sure that their needs are defined in these new licensing rules. And then we also have to make sure that we're in alignment with the Office of Developmental Disability Services, because we will need to amend both the state, what's called state plan, the 1915K, it's a state plan that we use to fund almost everything we do. And then OHA is going to have to amend their 1915I. And there's a very defined process that we have to go through to amend those state plan amendments to allow us to add agency with choice as a provider type. And then Oregon Project Independence Medicaid. I thought I would show you just some data. I know we've talked about this. So as of the end of December of 2024, as a reminder, we're still only working with individuals who are on the Oregon Project Independence wait list, or are who are not being well served in Oregon Project Independence because their needs are more intense. So far to date, we've approved 497 individuals. 18 of those individuals have closed. We have a variety of reasons. A couple of people, unfortunately, have passed away. Some people went on to the full Medicaid program because they wanted to go into an assisted living facility, adult foster home, et cetera. And a couple of people went back to Oregon Project Independence instead. So we currently have 479 people approved, and then 11 of the 497 are still waiting for their service plans to be approved. So to approve their service plan, they have to actually have a provider picked out. So they're still waiting to pick out a provider. And I think that was my last slide. Happy to answer questions, other ideas, thoughts.
Hi, Jan. This is Commissioner Adams.
Hello.
I was in the Washington DC CMS meeting, and they were saying the same stuff you were saying, but they also added that a person had 90 days in a grievance process, and then the state had 2 years to look at the grievance, and then within the 3 years, all states throughout all the states in this country need to be in compliance in 3 years. Did you get that memo?
Yeah, I think what they're talking about in that is not it's this phased in approach that they're doing with the access rule. So like I said, there's going to be expectations in 2026, 27, 28, 29, 30. And then by 2030, we have to all be in full compliance. And if we're not, then they can take away our waivers, which I don't think they will, but they could. But we're working very closely with the Oregon Health Authority and the Office of Developmental Disability Services to make sure that we are moving forward. And with the grievance process starting soon, I know 2026 doesn't sound like a soon, but it is in state government terms. So we're working jointly with those other program areas to develop a joint grievance process.
Okay, so when you guys are doing stuff or on your PowerPoint on facilities like the home, like the nursing homes and stuff, how much are you going to really be down on them for? I mean, is it going to be really tough because they have to be in compliance?
Well, I mean, our process usually with licensed care facilities like assisted living, so the access rule doesn't apply to nursing facilities. They have other regulations because this is home and community-based services. So it's assisted living, residential care, adult foster homes, group homes, and residential treatment facilities and treatment homes out of OHA. And then in-home, right, our in-home providers as well. So, but our normal step is to provide consultation and support to providers to attempt to get them into compliance, and then go through a progressive process of stricter and stricter penalties. So it may be a restriction on admissions. It may, or so if they have a contract with us with Medicaid, because don't forget, we also serve people who are not on Medicaid in our licensed care facilities. So if they're on Medicaid, we could do a stop work order. We're not going to admit anybody on Medicaid because you're not meeting the requirements. Then if it's overall the whole program is having a problem, the licensed care facilities, we can do an immediate jeopardy and put a restriction on admission. And then we give them time to get into compliance. And if they don't get into compliance, then they start receiving fines.
So is this going to cause us on the one system committee heartache when we're having to change things on that committee?
I don't think so. The one system is really financial eligibility for all of the programs. Well, most of the programs that require financial eligibility, but that's different than what this will do. So we will need to make changes to what's called Oregon Access. We may need a replacement for Oregon Access, but because it's the case management, long-term services, and support side of everything.
Okay.
Do we have any more questions for Jane?
One more.
Okay, George.
This is Commissioner Adams again. Jane Ellen, is your department and the two directors with everything that you guys are going to be required to do within this 26, 27 and other services. Are you guys also going to be prepared for the new draft that's coming out from the Human and Health Services from Louise and Washington?
On which piece?
It's where she has to do a draft and then people go over it and then she has to give it to her boss in Washington, DC. And then all the states like Oregon has to follow the new health and human service rules.
So I need a little, I think you mean Louise in the Administration on Community Living and the Older Americans Act programs?
No, Louise is the big, she controls the region of Alaska, Washington, Oregon.
Okay.
And Nikisha knows who she is. It's where she does the draft in Health and Human Service, and then she has to take it back to her boss in DC. I was just wondering.
Yeah, so any federal regulations that are coming in that require us to change, and I think I've talked about this a little bit before, there's changes to the Older Americans Act that we're in the process of implementing. There's changes to the Adult Protective Services that we're analyzing to see if we want to participate, because if we don't accept their federal funds, they can't mandate that we do what they want us to do. So we're still reviewing that. There's changes to the nursing facility regulations, but those have been put on hold because there's a lawsuit. And then there's this new access rule as well. So we're in the process of implementing all of the changes that we have to implement and are participating with Region 10 fully in the plans that they're creating and partnering with them on implementation.
You guys are going to be quite busy.
Oh yeah. Well, and then we'll be doing whatever comes out of legislative session, because it is likely that we will have a major bill on safety and oversight. We could have some other bills, and one of the things that will start in end of January, where am I? January 21st-ish, we'll be starting to do our weekly updates on legislation to community partners.
Okay.
Okay. Well, we thank you very much, Janelle.
You're welcome. Have a wonderful day, everybody. And again, I hope you're having a wonderful holiday season, even with the loss of Ruth. So thank you, everybody.
All right. Okay, strengths to you as you go through and sift
Thank
through
you.
all of this stuff. All right.
Thank you. Appreciate it.
We'll talk
Take care.
to you soon, I'm sure.
Thank you. Bye.
Now, it says, break. What time is it? It is 5 after 12. So are we still going to take our break? We're going to push forward?
I'm okay with it.
Anybody wanting break? No voices.
Sounds good to
Okay.
me.
To have a break or not?
Sure. Unless you,
To have a break, yes?
yes.
Yes. Okay, looks like we're taking a break then. All right. So, it is 12:07. So we can take a 15-minute break. And I will see you at 12:22. 1, 2, 2, 2. Okay.
Okay.
The recording stays on though, so you can mute yourself.
Marcia, I'll let Jason know that he needs to start a little bit later.
Oh, I overlooked him. Is he okay with that?
I'm sure he'll be fine.
Okay. All right, then we'll disappear until 12:22, and then we'll have Jason. Okay, goodbye.
Jenny, I needed to talk to you on the side. On the phone.
Okay. Can we talk a little bit later after the meeting?
Yes, as long as it's before 2 o'clock.
Okay. Hi, Andrea. We're just coming back from break, waiting for all the commissioners to come back.
Okay, thank you.
Marcia's back.
I'm back, Jenny. Commissioner Mayor.
Great, thank you. I don't see Jason yet, but Andrea's with us. I imagine he'll be joining shortly.
I'm back.
Let me make sure he's not having any difficulty getting in. Marcia, it looks like Jason and Andrea are here.
All right. Well, welcome. And we have Jason and Andrea. Will you please start and give us some more information about what has happened lately with Agency with Choice? Thank
Hi,
you.
everyone. Jason Pruitt here. I use he, him pronouns. Glad to see you all again. I think, gosh, the last time I was here was maybe August. Is that right? But anyway, I do have some updates for you. One of them is that we've hired Andrea as the operations and policy analyst for the Agency with Choice program, and really glad to have her contributions. The biggest work that we've been doing is on administrative rules. We had one rule advisory committee meeting in December, and we have 3 more planned for January. So doing a lot of work there, collaborating with folks, just realizing what a task it's been to write a whole new chapter of rules and try to incorporate everyone's feedback. And it's been a good process, but challenging as well. We have been working with the Oregon Health Authority quite a bit through this process. As you know, the bill is directed towards both DHS and the Oregon Health Authority. And in working with them, we've decided that we're going to do a co-licensing of these providers because we realize that could potentially be very confusing and hard to have multiple regulatory oversight bodies over these providers. So we really just want to work together with our partners at the Oregon Health Authority. And so that as we work to contract with these vendors, that they just have one kind of entity to report to. In terms of other work, I just received the approval for some more position authority to hire a learning development specialist 1 and 2. So going to be working with our training unit for services and supports team that has all of these classifications to help me on that recruitment so that we make sure that we can really identify those desired attributes and kind of the key pieces that we want from the people selected. Behind the scenes, we've been doing a lot of work with our Office of Contracts and Procurement, getting our statement of work and getting our language together so that we can be ready to move forward with that procurement. also been working internally a lot with our IT department so that we're ready to be able to bill, have these providers bill through our existing billing systems to make sure that we have the right funding codes, that we're able to have the accountability and oversight of the money. Also been working with our provider enrollment team. You know, within these agencies, we have so many different units, and one of them is provider enrollment. And so what that looks like is, what is their Medicaid provider agreement going to look like with these vendors and DHS and the Oregon Health Authority? And then finally, also, we're getting ready for the work that will need to be done around our state plan amendment changes. And so with that, we'll be aiming to have our design and implementation council, I think in May or June. And so we have a lot of, you know, a lot of different things on track to make this project a success, and to open it up to any questions that folks might have.
Hi, this is Commissioner Adams, Jason. When do you think you'll be able to get this up off the ground?
So the bill actually mandates that we contract with these providers by December 31st of this year, 2025. And so part of the impetus for us really having to move on this project is that legislatively mandated timeframe. So I envision, you know, that we sign contracts by the end of this year, with the goal of services beginning probably July of 26. That would give the vendors about 6 months to get all their ducks in a row and give us time to license them and make sure that they're ready to go.
What is your estimate on how many providers or vendors you figure you're going to end up with?
So the bill directs us to contract with up to 2. So we can have no more than 2 is how we interpret that. That being said, I don't know how many could potentially bid on the procurement, because it will go through an open competitive procurement process. And so what we'll be doing is looking at our, evaluation criteria and selection committee to determine which vendors are the best suited to provide these services.
I'd like to make a suggestion, and that would be that once all this comes together, that the vendors and providers understand that the people in the disability community is very important when applying these types of situations and services.
Yeah, I'm glad you mentioned that. Some of the key pieces from the legislation actually mandate that these providers have a quality assessment improvement process that incorporates voices of both the people they serve, the providers, the direct support workers who they employ, and even I think members of the Home Care Commission. And so making sure that voices are heard and that they can continually look at ways to innovate in how they provide services.
Jason, this is Commissioner Wenzel. Will these will these vendors be ones that already exist and have a track record that can be evaluated, or are they just newly created that could work for that could be a vendor?
That's a great question. Until we open up the procurement, I don't know who is going to, put in their bid, right? I suspect that one of the evaluation criteria that we are really going to look at is a past history of successfully providing services in this way. I that's just my feeling, but we haven't finalized, all those criteria. And again, I don't know how many folks are going to bid and where they might be coming from either.
I I hope that we can evaluate their history. That would be great. Thank you.
Yeah, I absolutely agree. That's important.
Any more questions? You have more to share with us, Jason?
That's really about it. You know, the big updates are just with getting the administrative rules. You know, we have, like I said, the 3 more rule advisory committee sessions this month. And you know, once we get those finalized, that's really gonna, I think, you know, get the ball rolling in a lot of different areas in a big way.
What administrative rules have you covered already?
I beg your pardon.
What administrative rules in the rack have you covered in the first rack?
So for this program, we actually had to write an entire new chapter of administrative rules, just outlining the agency with choice program and all the different parameters. And so folks have reviewed one draft. We've sent one draft. And, you know, as with anything, it's a bit of an iterative process. So there's been revisions, and we're going to be going through those revisions. And hopefully, you know, my goal is that the end product really reflects that iterative nature of hearing the different voices and perspectives.
Is that a public document?
Yeah, it's all posted on our Rule Advisory Committee website. And the Rule Advisory Committee meetings are public, but we do limit discussion to the members, you know, but have a comment period at the end for any public participants who are not members.
Okay, thank you.
And Andrea can put the link to that website in the chat here. Well, commissioners, thank you for having us here today. Always glad to come back and provide any updates as they occur.
All right.
And hope you all have a nice new year.
You too, Jason. Thank
Thank
you.
you.
Bye.
Bye. Marcia, I'd like to introduce our next speaker, and she's going to introduce our guest today, if that's okay.
Of course.
Okay, I'd like to introduce Monique Cole. She is a policy analyst with a Medicaid Long-Term Services and Supports Unit.
Thank you, Jenny. Hello, everyone. My name is Monique Cole, and I use she, her pronouns. And like I was introduced, I'm a program analyst for Medicaid Services and Supports team. I'm here today with a team from Life Course Nexus with the University of Kansas City, Missouri, and Alvarez and Marcel to share information about a project APD and Life Course are working on together. This project will help us understand what changes are needed in case management to improve our approach to person-centered services and to align with upcoming access rule requirements recently released by the Center for Medicare and Medicaid Services, or CMS. Life Course Nexus will develop recommendation reports to help enhance person-centeredness, operations, and outcomes. And they have met and will be meeting with several different groups, including home care workers, to understand what it looks like from when an individual comes to our agencies needing help to when they start receiving services, and all of those things in between. So that being said, I will go ahead and pass it over to our Life Course Nexus and A&M team to provide more details on this work. Thank you so much.
Thank you.
Good afternoon, everyone. It's good to see you. I'm Amanda George, and I work at UMKC and use she, her pronouns, and long-term supports and services is the area at the Nexus where I focus. And I'll let everyone else introduce themselves.
Hey there, my name is Megan LaMarche, also she, her. I'm from UMKC. I work alongside Amanda on this project. Okay.
All right. Hi, everyone. I'm Karen Dorbin. I'm from Alvarez and Marsal, and we are partnering with the Life Course Nexus, and we are very excited to work with them on this project. I also use she, her pronouns.
Hey everyone, I'm Erin Levitin. I'm a partner at A&M. Pleased to be on with all of you. I've been working with the Oregon Department of Human Services over the last couple of years, and I'm really pleased to be doing this work now with APD through the Nexus.
Hi there, my name is Kayla McCollum. Hi, sorry, we've had some. Got it muted. Sorry, not trying to have echo sounds. I'm Kayla McCollum. I also work at UMKC with Amanda and Megan and kind of partner on some projects with A&M with Karen and Aaron. And been at the Nexus for a few months now. I'm excited to partner and support Megan and Amanda in this work. And I also use she, her pronouns.
And you may have guessed that Kayla and I are sitting right next to each other. So yeah, we'd love to learn a little bit more about this group, the Oregon Home Care Commission, and would love to know who we're meeting with. Would you be okay with doing quick introductions? Great.
I'm Commissioner Adams down in the south part of Oregon, called Southern Oregon in Medford.
Hello, I'm Commissioner Johnson. I'm the commissioner who represents APD on the Home Care Commission.
Right away. I'm Commissioner Mayer. I'm in Northeast Portland.
And I am Commissioner Wenzel. I live in Salem, the capital of Oregon.
Thank you.
We're missing a couple of commissioners today.
Yes.
I'm Jenny Coakley. I'm the Executive Director of the Oregon Home Care Commission, and we are missing Randy Moore, who's a representative of the Oregon Area Agencies and Area on Disabilities, Aging and Disabilities. We call it O4AD. I'm sure I just messed that up. And then also Mark King, who is a Consumer Receiving and Home Services, consumer representative.
Okay, have we heard from everyone?
Those are our commissioners. I wasn't sure if you wanted, we do have some staff members if you want to hear from them as well. Okay, Nancy, do you want to introduce yourself?
I'm Nancy James. I am the Employer Resource Connection Coordinator, temporarily sitting in to take minutes and run things.
Great, thanks.
And Roberta?
Hi, everybody. I'm Roberta Lilly. I'm the manager of the training unit here at the Oregon Home Care Commission.
Great, thanks.
Okay, that's everyone.
Okay, great. Thank you. Wonderful to meet you all. All right, I think, let's see, I'm able to share my screen. Is that accurate?
You should be able to if you would like. Yes.
Okay, great. Just want to make sure, Megan, did you want to do the first part or?
Yeah,
great.
I sure can.
I can share my screen if you need me to.
Yeah, that'd be great. While she's pulling that up, basically, we're really here to get a sense in all of these conversations with different folks to really get a sense of what is the culture at Oregon APD around person-centeredness, whether that's at the front door intake where people have their very first interaction with someone all the way to their quality reviews and interacting at that point. So we're really here to just kind of get a sense of all of that. I know we've only got about 20 minutes with you folks today, so that it's a little bit less time than we've had with most others, but we are so excited to chat. So we're just going to quickly go over a project overview. We are also completing a review of quality and compliance indicators, and we'll be looking at case management and person-centered training as well. And then on the next slide, we've got our timeline. It's a very fast project, so we're actually going to be wrapping up and handing over a final report at the end of March. But along the way, we're really using the feedback we're gathering from all of you to co-create and inform a set of recommendations that APD can consider in moving forward in the future. We're talking to a lot of different folks today, so you're one of our later conversations, I think. We've got a couple more to come. We have some listening sessions we'll give you a little bit of information on if you want to attend one of those and share additional feedback. And we will have a link to drop in the chat as well if you want to provide any more feedback over email or a phone call. So we've got several different opportunities to interact, and we will share each of those. Back to you, Amanda.
All right. Okay. So you may or may not be aware of Life Course Nexus. So we just wanted to give you a really quick overview of person-centered practices and systems from a national perspective and from the Life Course perspective. And again, we have very limited time, so this is going to be a really quick just overview. But really what we're here to do is really focus on the why of which is person-centeredness and good lives for all Oregonians. We spend a lot of time in our system doing the what and really figuring out how to stay compliant with all the rules and regulations. And this project is so exciting because we're going to get to focus on more of the how of person-centeredness in providing services and designing the system, as well as making sure person-centeredness is experienced at all levels of the system. And person-centered systems have really, I've been in this field for over 30 years, so I've seen a lot of progress in the last 30 years around person-centered systems. And now we have federal rules and regulations really trying to make our systems for people who are aging and with disabilities person-centered. So we have lots of rules and ways to go about doing that. Basically, when we talk about person-centered approach, there are three pieces to that. There's the person-centered thinking, which really seeps into all that we do. It really is foundational, and you can't have a person-centered system if people in that system aren't really thinking in a person-centered way. People who work in the system, as well as people and their loved ones who receive services, really knowing they are the experts and being able to act on that in the supports and services that they need. Person-centered planning is how we come up with the person's vision for their good life, and then usually that directs the services the person receives. And then person-centered practices is really getting all that aligned so that person-centered thinking can be implemented at all levels of a system. And again, the NCAPS is the kind of national organization that's supported by the ACL. Is that right? Sorry, I get my acronyms all confused. Administration on Community Living. Yes, got it. ACL. And have set these 9 elements of a person-centered system. So we're going to be looking at Oregon APD and applying these 9 elements to the current system. And then this is the person-centered planning competencies. Again, we'll be using that as we look at how case managers are planning with people. And we'll do that all through the lens of the Charting the Life course framework. And we have at the life course framework has guiding principles that really help us shape our person-centered thinking approach. We have tools and resources that we use for planning and problem solving and really just exploring what a good life is. And then the practices we've at the Nexus have some ideas about how to help systems become person-centered. These are the principles. There's, of course, more training where you can get more information on all of these, but these are some of the essentials that we believe are important to support the core belief that all people have the right to live, love, work, and play, and pursue their own life aspirations. Excuse me. So with that quick overview, we really weren't sure how many people were coming today. So we had an opportunity to use Menti, but I'm kind of looking at Megan to see.
Yes,
how
I just dropped it in the chat. So
okay.
you've got a QR code. You can also just go to menti.com and type in the code that is on the screen. And then I've just dropped in the link in the chat as well. It just has the questions if you want to respond more at with words instead of written words instead of verbal words. I'm better with written words than verbal.
The next slides will explain to you the questions we're going to be asking, and you don't have to use Menti. It's not required. It's just an option.
Yep.
So I'm turning it back over to Megan.
So really what we want to get at is especially from this group that represents a variety of different roles and perspectives is really what do consumers and families want from Oregon APD as a system? And then also from your own perspective, what would you like to see? So I will open it up there for you all to kind of reflect on that question. And you can also, we try and start with the top box, but we also know that it's often easier to think about what you maybe don't want or want to avoid. So we'll go either direction.
Megan, do you want me to keep sharing just so people have the graphic?
Yeah, sure.
Okay. So what's your preference? Would you like to unmute and give us your feedback? Or would you rather type in chat?
Usually the commissioners prefer to share verbally. Could you repeat your ask for them, please?
Sure. Yeah. So what we are wanting to learn is really what do consumers and families want from Oregon APD? So if you'd like to share any thoughts about that, we've dropped a link in the chat that you should be able to click and go to a site that will have the questions right on it, or you can go to menti.com, MENTI.com, and enter the code that was on the previous screen, which I will now go grab.
Or they can share it now during the meeting?
Yeah, absolutely.
Yeah, or now. So either way.
Yeah, so we want to make sure that we give all the input that we can back to APD about what a person-centered system will look like. So we want to get your perspective on what do you think people want and what a person-centered system would look like. And then what don't you want? And then we're also going to talk about what is going well right now, what are the opportunities, and then what's not working well, what are the barriers. So please feel free to speak to any of those questions right now.
Well, this is Commissioner Mayer. I don't know if this is what you're looking for, but I would, my definition of person-centered would be somebody who's in control of their life and can do what they want to do within capabilities. And like a terrible thing would be if somebody's making all the decisions for me and doesn't include me in those decisions, whether or not I can do them or not. That would be just terrifying to me. Because independence is very important, I think. And being a baby boomer, I guess that's a definition almost. But I don't know if that's what you want, but
Yeah,
that's what it is.
absolutely. Absolutely. So, and just to kind of follow up on what you said, Commissioner Mayor, right now with the APD system and the services and all of the things that are offered, what's going well with that vision that you have, people getting to kind of call their own shots and make the decisions, and what isn't working well?
Mm-hmm.
This is Commissioner Adams. I think basically consumers and families and such would like a faster response, someone to go to when there's a problem. The department to know what they're talking about. That's all on the same line, not having to go one to one person and get an answer and then go to another person and they don't know what the answer is. Better customer service at their branches.
What would good customer service look like?
Hi, my name is so-and-so. How may I help you? When they come up to the desk. Someone that smiles, someone that's not like, I don't like my work. Someone that some people in the department understanding more of what the disability community is all about, understanding the very core and the terms, words that are applied to community, the disability community.
Mm-hmm. I'm hoping that all the commissioners take this opportunity to share information, because this is an opportunity for this information to be put into recommendations and a report to aging and people with disabilities. But I can understand if people don't feel comfortable speaking up, but I strongly encourage you to provide that feedback in the different ways that Megan and her team have provided. So yeah, please feel free to share your thoughts right now.
Okay, Jenny, it's Marcia. It's your
Okay,
fault.
good. Good. I was waiting for you, Marcia.
Okay. I have had a team of providers for quite a while, and they have changed quite often. A problem I often incur is when you make a request, provider will say, yes, oh, yes, yes. And I feel that they're honoring person-centered care. And then they're out of my sight and do whatever they want to do. And, whatever their habit is, a way of doing something, they do it or don't do it. I feel quite often like I'm talking to the wind, and it makes me feel sometimes helpless to get accomplished what I would do if I could do it. Yeah, it causes a great chafing in me. So there's that one. I think in the training, somehow, they need to communicate that person-centered care, in order to give it, you have to leave your ways of doing things outside the door. And people, pardon?
Such a great point.
Yeah, people aren't used to doing that. More so in current times. They want their opinion, their point of view. And they don't have to challenge you verbally to do that. So I've had, but on the other hand, I have many absolutely wonderful care providers. There's another issue that I've been scratching at for a long, long time. There's a difference in what a personal support worker does with their consumer and a home care worker does. A personal support worker is to encourage their consumer and equip them with skills to do things more independently. And they are required to go with them to do all the things that need to be done to run their life and household. And the consumer has the prerogative to say, I'm going to go see Gladiator. And there they go. Now, home care worker does not have that same mandate. And although it's been told to me verbally that yes, they may go outside into the world with you, it needs to be in print because it causes different opinions. I might want to go for a breath of fresh air, and provider number D says, no, 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 it doesn't say you can go outside under a tree. And it makes it sometimes seem not worth it. I think it contributes to social isolation. Well, let's get the words out. Social isolation and depression. And you need that to fulfill a good life. You can't just have contact with your home care workers. It's a small circle, and they're being paid to listen. It's different than being able to go and see a friend who is just a friend. I miss those connections. And the home care worker is tied to a very tight schedule. There isn't a lot of, where is the time that you could go, if you have to have your home care with you, a home care worker with you because of your medical needs. For instance, I would use a power chair, I need oxygen. I need somebody along. You would use up so much of your other care time that things will come out of balance. So somebody needs to decide how much of my life I could actually pursue. I want it all, but it's unrealistic because of my disability that I can do that. I still have, pardon me, I still have a zest to run a race, but right now I'm stuck in bed. I do my racing with Oregon and participate with you folks in commissions, race commissions. But I would love to bring that ability to go where I wish on a whim, to make it a reality and come out of the gray shaded area. There you have it, Jenny.
Thank you, Marcia.
Thank you, Marcia.
That was so powerful. Yes. Thank you so much for sharing.
Commissioner Wenzel, sorry.
That's okay. I'm post. Just have to change my hat. Just sure.
Yeah, this is Commissioner Johnson, and a few years ago, Matt Raposa made a brief video on person-centered programming and care, highlighting Marcia and Ruth, our commissioner who recently passed away, our chair, and it might be helpful to send that your way. I think you would find it helpful from these two ladies' perspective, folks who have received services for many years, how they would like to receive person-centered care. So I could send that your way, or Jenny or someone possibly. I think it just might be helpful to see that information since it aligns much with this conversation.
Thank you, Paul. Ruth and I did that with Matt Raposa, and we didn't know the questions he was about to ask us, and it just sort of all came together spontaneously. We didn't have a script, or we just shared the difference when you look at two people using wheelchairs, how very different their need for care could be, and but their zest for living is similar. So there are many types, not just wheelchair users and another category. Anyway, I'll stop talking. Thank you, Paul, for bringing that up.
Yeah, that is great. I thought I recognized your voice a little bit, Marcia, because I think I saw you in the training video recently. But we really do so appreciate your time today. I know it's a couple minutes past our time here. But is there anything else folks would want to share with us before we conclude?
Yeah, this is Commissioner Adams again. I think, in my opinion, there's been many consumers that has mentioned many times years back that they needed someone in the APD and ODS department to really get a hold of somebody when they can't get a hold of their case manager or someone in the office. Someone that is willing to say, okay, I'll take care of it right away and get back to them within less than a week, without them having to wait weeks and weeks and weeks and weeks and weeks and weeks and never get nothing accomplished. Because things happen in life. Also, when they have a problem with someone that is not part of the family, they need to get a hold of someone in the department that will kind of sort of say, okay, well, what can I talk to you about? Just to talk things out. And as Commissioner Winslow was saying, most of, or if some of consumers like to be independent. They want to live their life, but some of them can't. That would like to be changed without, because there's certain rules and regulations that you can't do or else you're in trouble. You got to follow the rules or else. That's what, that's what some consumers are up against.
I feel like we could talk for a long time. Listen to you. And since our time here is short, we do have some other opportunities for engagement that I wanted to share. Before I do that, are there any other comments people wish to share about how the services and supports could be more person-centered?
This is Paul Johnson. The only comment I would make, and I'm not a person receiving services, and so I defer to those wonderful folks who have that perspective. But I think just sometimes we just want to make sure that we are reflecting not just an individual's perspective, because a lot of person-centered care reflects a communal perspective. If someone's in a different culture or background, or in a particular area, maybe of the state, or whatever, their person-centered care may be best received in more of a group way than an individual way, depending on the position of a person in their family, particular cultural norms or standards that they are part of, various factors, and so I would just want us to factor that in, that it's that I think sometimes, and I don't want to make a blanket statement here, but sometimes it's easy just to think of the individual, and yet the individual is part of a family, and they're part of a subculture, or they're part of a culture, an immigrant group, a particular language preference, etc. And that may obviously impact the way in which they desire, they would envision person-centered services. And so I know these things are understood, but I thought I would state them because it makes it so difficult, but also so challenging and exciting to discover what person-centered means for an individual that may not see themselves as an individual as much, more as part of a group.
Thank you. Okay, I'm going to share my screen again to show you some upcoming dates. I thought I was going to share this. Not, okay, one more time. There you go. So we have a couple public listening sessions that you could attend, or anyone that you think would want to be heard. They're coming up this month in a couple weeks. The first one, the 16th of January, and then the next one's the 24th. Go. And if you do want to know, if you want to talk to us over the phone or email, we do have this link here that I think Megan can also drop in the chat, and we will definitely figure out how to reach out if you have another way you'd like to do that. I know this was short. We just really wanted to let you know about the project, that we're here to listen, and that there are other opportunities. And And then questions, anything, you can reach out to Monique. She's really great with getting us the contact information of people if, or passing information along as needed. So I'll stop the share.
Amanda, when would you need everybody, if they want to participate, what's the due date for that? When's like, you're collecting information through which date?
Really good point. I would say through the end of January.
That's just what I was thinking too.
Yeah, our report's due in March, so we have to have time to synthesize all the information and put it together in a helpful way for the state.
And commissioners, you've been sent the PowerPoint presentation and the link should be active in that presentation.
Yes.
This is Commissioner Adams. Once all that is put together, is there a way us commissioners could get a see how it all came out?
I don't want
I will defer to Monique, but I believe there will be an opportunity. Yeah, certainly.
Yes, there will be an opportunity to share that information.
Is that going to be available to the public, or is this more internal?
It's internal.
Internal, okay.
I think we have completed our presentation and engagement with you. Thank you so much. Appreciate the time. Happy New Year.
Thank you.
New Year.
You too.
Thank you so much for coming and for your flexibility today.
Absolutely. We're so glad we got to hear from you.
All right. Thank you so much.
Thank you, everyone.
Thank you.
Bye.
Bye-bye.
Marcia, this is Jenny. So there were still a couple of things we didn't get to, which is all the commissioners providing their updates. And then also information about the strategic plan. It's 1:14, so I wasn't sure how long everybody wanted to stay on today. We can always move the strategic plan discussion until next month. I did send a document that David prepared talking about where we are with certain projects or what's been completed and what's in process. So I will leave it up to, I don't even see it on the agenda now. Marcia, would you like the commissioners to provide updates on their various committees? I think we might have lost some people. I don't know what happened. Marcia?
Muted.
Oh.
Okay. Governor's Commission for Senior Services, Mary?
Okay, well, the last time that we met, last month, the Legislative Committee wants to become more knowledgeable about what particular legislative initiatives may be out there. So we are asking, or they are asking for 6 people to come in and give a legislative update of about 20 minutes each. And the 6 organizations are the Oregon Gerontological Association, the O4AD, the Age Plus, AARP, SEIU, and Oregon Public Guardian. So I'm anxious to see what they have to present, and if it's applicable to OHCC, I will certainly bring those back with me. But that should be, and that's all we're going to do for that particular meeting. It's going to be next Thursday from 9:30 to 12:30. And that's my report.
Okay, thank you. Oregon Disabilities Commission, Commissioner King is not here today. Um, I'm also on that commission. So I will just say we are going over our goals for next year and trying to connect with what agencies our goals touch. So we are better at communicating. But that's the end of my report. OA4D, Randy's not here. APD.
Yes, good afternoon. This is Paul Johnson. I don't have anything pertinent to present right now. Work is ongoing, obviously, in APD, and I checked with Matt, and we don't have any updates at this point to share or new information to share, although you were able to hear from both him and from Jane Ellen today. So that was some helpful information that she provided on agency of choice and some of the other programs. But otherwise, I don't have anything beyond that to share.
Thank you. Community advisory councils. CCO. Oh, George, you're still with us.
Yes. The thing with that is OHA has decided to bring in the HERC. And then there is an application that's out and wanting people with a disability to join what is called the HERC Disability Committee, which is on the side, which is called like a subcommittee, I would guess. And they want their intake as to what they think about what could be approved and not approved for medical services. When the CCOs do not want to approve certain type of services like spinal cord injuries, people that are allergic to things, just off the way things. So like it's so they wanted to put a committee together, people with a disability, on the side of the HERC to ask for, again, what they think should be approved and what not be approved in the medical field type stuff. And then they're going to also ask the HERC what needs to be approved or not approved of what the CCO can't approve. I don't know if you can understand that, but that's how the whole system, how OHA wants it to be set up come 2027. The CCOs and the two entities between Jackson Care Connect and Care Oregon, they're attached together. They're kind of Medicaid / Medicare. So they're very concerned about what's coming here in the whole additional year of the 2025 of what Medicaid and Medicare is going to be approving. Some services won't be approved and some services will be approved. And then the NEMT service, I've got a meeting with that coming up this month that I'm going to be going over. And I can give you more of an update of what's going on there in the next coming meeting in February. And that's all I got to report.
Thank you, George. Okay. Now, will we do Nancy's report now?
No, that was the old agenda, Marcia.
Oh,
we bumped Nancy so that we could have our guest speakers from the university.
All right. Okay, so this is David's submission.
Yeah, so at the last commission meeting, the commissioners wanted an update about the progress we're making on the strategic plan. And he broke that out by goals. So the first goal was to develop tailored communication materials and a plan. And the action required was work requests submitted to publications and creative services for revisions, and that's been completed. They have been submitted. One of the things we're looking at is redoing our flyer for and our brochure for the commission and to recruit commissioners. Also, a one-pager is being created for contact with legislatures. That's currently in progress. And research and analyze demographics for outreach, that's pending. The next goal is to launch a social media campaign, an OHCC Power Hour. The action was to increase OHCC visibility on Facebook, and that's in progress. We are having more frequent posts, so if you're not following the commission on Facebook, please do so. And then we are working on a schedule for power hours for 2025. That's in progress. And that will be for providers having like 1 hour presentations as a way of hearing new information, learning, learning about topics that they may be interested in. Another action, conduct interviews with OHCC staff, and that's in progress. David developed and refined interview questions to ask the staff, so that's completed. Review all OHCC services for strengths and improvements. Sorry, that was those actions, the interview questions and interview with staff. That's still in progress. The fourth goal, identify key partner agencies. So pending actions, research state and nationwide organizations working with in-home care consumer employers and providers. The fifth goal, recruit new commissioners to meet representation gaps. So assess current needs and representation among commissioners. That's complete. Meet with ERC consultants on how to discuss with an individual about becoming a commissioner. That's in progress. And research how to make changes to the commission makeup to include ODDS and the behavioral health program with the Oregon Health Authority, and that's pending.
Turning copies, she needs the originals.
So here is an overview of the strategic plan, just a snippet from the larger timeline of the timeline we're looking at. So most of these activities are starting in January and going through the first quarter. Some will start in February, the identify key partner agencies. So that is a quick update for today, and then next time David can provide a more in-depth discussion. And that's it.
Looks like we're come to the end. All right. Anyone else have a comment? Or we will, and then we will adjourn.
This Commissioner Adams, Jenny, did you want to comment on the on branding from the governor's office?
No, I don't have a comment about Brandy. But I thank you for the reminder. I did send out an email notifying everybody that there is an orientation for board commissioners and board members that Aging and People with Disabilities is doing based on a report and recommendations from a contractor they used about making commissions and committees more diverse. So I've sent you that information. If you'd like to take part in that training, please add that to your calendar.
Okay, if we have no more discussion, I will adjourn the meeting at 1:27.
Thank you, everybody, and Happy New Year.
Happy New Year to you too. Bye.
Yes, bye, everyone.
Bye-bye.
Jenny, I'll wait for your phone call here before 2.
Okay.